Let's see here. Let's see here. Somehow or another, it looks like I selected the wrong screen to share. Here we go. Okay, so welcome to week 8. There's quite a bit of information this week. So what we're going to do is we're going to go over 2 chapters. We'll take a quick Kahoot. We'll do 2 more chapters. There'll be another Kahoot, and you guys take a break, and then you come back for your quiz 5. There is information from today's class that's on the Kahoot, or that's on the quiz. So there's, I mean, that's just kind of the way the quiz was put up in the syllabus, and I can't really change any of that, but I did go through and make sure I point out stuff in the Kahoots that I know you need to take your quiz. So my one piece of advice for you today is, obviously I want you to pay attention like you always do, but focus on the Kahoots, because I'm going to make sure that I give you some direction in terms of the quiz that you're going to take at the end of class. So to get started, does anyone have any questions about the homework or anything? I mean, I know that you need the study guide, but is there anything else going on that you guys want to talk about before we get right into this week's material? No? Okay. So we're going to start with genital urinary conditions, and then we'll do skin, and then we'll do a PowerPoint. I'm just going to take this off really quick to put my glasses on. Okay. So unfortunately, when we work in pediatrics, we always have to think of the possibility of abuse. So when we're, evaluating children that have genital urinary problems, if they're being abused, this would be one of the body systems where there might be indications of abuse. So just to always remember that, frequent urinary tract infections, bedwetting, nightmares, pain in the genital area, urinary frequency, all of the, excessive masturbation, obviously, but all of these things, many of them can be associated with like a urinary tract infection, or they can also be associated with abuse or abuse with a urinary tract infection. So just always have that in the back of your mind, that if you're having a child that has like frequent urinary tract infections or, ongoing complaints having to do with their genital urinary area, that should be a red flag for possible child abuse. So when we're talking about the genital urinary system, we're talking about the genitals, the urethra, the bladder, and the kidneys. So there's a lot of different, pieces to the genital urinary system. And there's a bunch of different tests that we can do to evaluate the entire system. So you don't really, need to know too much information, just basically understanding that it's not just the bladder, and it's not just the genitals. There's the urethra, the bladder, the ureters, the kidneys, and being able to look at all of that will help you figure out what's going on if they're having a problem with the genital urinary system. So these are some common terms that you should know. So does anyone know what dysuria means? What is it when you document or you read in somebody's medical chart that they have dysuria? What does that mean?
Difficulty urinating.
Okay. And then frequency. I mean, it just means frequency, right? So they have to go pee a lot. And urgency. And how do you think urgency differs from frequency?
Urgency is when you have to go like really bad, like a sudden urge to go.
Yeah. And you feel it like, like I don't know if any of you have ever had a urinary tract infection, like you feel like if you don't get to the bathroom, you're going to pee your pants. And so you have that you feel like you really need to go. And then nocturia.
That's urinating at night.
Yeah.
Where to use the bathroom.
And then polyuria.
A lot of urine.
Yeah, you have to go a lot. And then oliguria. This is the opposite of poly.
Not producing enough urine.
Yeah, so someone that's like going into renal failure, they're going to have oliguria. Very good. So there are some specific sort of abnormalities. These are going to be abnormalities that they're born with, so they're congenital. So these are specific to males. So a narrowing of the opening of the foreskin. So like before a boy is circumcised, and not all boys get circumcised, if that foreskin is too narrow and they can't pull it down and push it back and forth. So it's the foreskin cannot be returned to its normal position. So it can be something they're born with, or it can be something that goes wrong. Like when you're cleaning the penis, you push it back and then they're swelling and they can't get it back down. So it can be both, but it can cause constriction, and sometimes they have to have surgery to fix it. So if they have phimosis, you do need to get them evaluated. And then epispadias and hypospadias, these are also specific to boys. And this has to do with the position of the urethra. So the urethra is the tube where the urine comes out of. So if they have epispadias, it's on the, instead of being in the middle of the shaft of the penis, it's on the upper part. And if they have hypospadias, it's on the bottom. So these are the pictures. So this is what epispadias look like, and this is what hypospadias looks like. So these are things that you'll see problems with their urinary stream, usually when they're pretty young, soon when they're born. So if it's not a big, if they don't have a hard time draining their urine, if it doesn't spray all over the place, they don't necessarily do surgery. But a lot of times, because of the position of the urethra, the urine just kind of goes all over the place. And they can also sometimes have a hard time draining all of their urine. So in those cases, they would need surgery, and they usually do it before 18 months of age. And they recommend that the parents don't circumcise because they'll use that foreskin for the surgical repair. So once they've had their epispadias and hypospadias repaired, then they can have a circumcision if the parents want it, but they need to leave that foreskin intact so that they can use the foreskin to repair the defect. So exstrophy of the bladder, this is something that can happen in both males and females. This is extremely rare. This is where the abdominal wall is missing, so the bladder is exposed. So you're going to see this before they're born. You'll see that on a prenatal ultrasound. So the bladder is exposed on the abdomen. Urine leaks continually from the bladder, and that irritates the skin. So you're going to cover, it sounds kind of gross, but you're going to cover the area with plastic so that you can't get infected. And they're going to have them on their back so they can't put pressure on the bladder. And then they're going to need surgery. So this is something, they almost always see it, on the prenatal ultrasound. So you wouldn't, have the kid born and unexpectedly see exstrophy of the bladder. You would almost always see it before they were born on the ultrasound. And they're going to get surgery right away in their first 48 hours of life. So when we're talking about obstructive uropathy, we're talking about an obstruction somewhere in the genital urinary system. So remember, it's the urethra, the genitalia, the bladder, and the kidneys and the ureters. So an obstruction somewhere in there, and it can be, a tumor, scarring, a stricture. Hydronephrosis kind of refers to the top part of the kidney that gets inflamed. So depending on what's going on, they might have to have surgery to repair wherever the obstruction is in the genital urinary system. So an acute problem that's related to the genital urinary system is going to be a urinary tract infection. So girls get UTIs more common than boys. Does anyone know why girls get UTIs more commonly than boys?
Is it because of the urethra is shorter?
Yeah, the urethra is shorter. So just think about like the penis, and the urethra comes out the end of the penis, and that's farther away from the body than the vagina. So it's just closer to the rectum and where poop comes out. So the most common organism is going to be E. coli, which is in your poop. So just, a lot of urinary tract infections in girls, this has to do with, not wiping from front to back or taking bubble baths and kind of getting that area inflamed or irritated. So, you do a lot of education in the primary care world about, wearing cotton underwear, having them be loose fitting, minimize bubble baths, and then retention of urine. So you want to make sure kids are going and peeing on a regular basis. When there's stasis or when the urine's not leaving the bladder, it's a setup for infection. And then vaginitis is kind of an irritated vagina, and all of those things can be set up for a UTI. So normal urine is acidic. So if the urine for some reason is becoming more alkaline, then that is another thing that predispositions girls to a urinary tract infection, or boys. So what do you think you can do to help change the acidity of the urine or make it stay acidic? What have you, like all you women out there, have you ever been recommended that you drink something in particular?
Cranberry juice.
Cranberry juice, yeah. Cranberry juice helps change the pH, helps keep it acidic, and so does orange juice. So these sorts of juices that you drink can kind of help alter the pH and make it less likely for you to get a urinary tract infection.
Mm-mm.
So, obviously the signs and symptoms are going to be somewhat depend on the age. Like a baby can easily have a urinary tract infection, but they can't tell you that it hurts to pee, etc. So kind of be aware, fever in a child could be a urinary tract infection. Kind of keep that on your list of differential in terms of what might be going on. And I think I've talked about this before. If you suspect a urinary tract infection in a child that's diapered or not really able to follow commands, how do you get the urine specimen that's going to be the best specimen that'll tell you what the bacteria is?
Isn't it from like their wet diaper?
So this is the thing, it's easiest to get it from their wet diaper, but the best sample is going to be a straight calf urine sample, which parents hate, but it's really hard to get a good sample from the diaper. So sometimes hospitals will clean the area and they'll put like a bag over the vagina or the end of the penis and have them pee into the bag, but that's still a risk for contamination. So the best sample, and if you're ever tested, the best sample, the best way to get a clean urine for culture in a baby is a straight calf urine sample.
I have a question.
Yeah.
When it comes to doing that, wouldn't we want to go the minimally invasive way first versus going straight cath when it comes to NCLEX?
So I do understand, yeah. So minimally invasive, but the problem is that the less invasive, they don't have a good result. You're likely to get a bunch of different bacteria in there, and then it'll be hard to know which antibiotic is best. So the
Okay.
straight cath will give you like the bacteria that's causing the problem, and then it's going to be more likely that you can treat it effectively. Because if you don't do the straight cath, you might end up picking an antibiotic that doesn't treat it, etc. So I totally understand, but like 100%, if they're in diapers, the best urine sample is going to be a straight calf.
Okay.
So, these are some basic things that we've talked about in terms of like keeping the genital area clean, the cotton underwear, etc., wiping from front to back. So urinary tract infections is acquired, obviously. Nephrotic syndrome is like an umbrella term for a series of kidney dysfunction where they spill a lot of protein in the urine. So it's more common in boys than in girls, and it's usually autoimmune related. So they usually have some sort of autoimmune process that sets off inflammation of their kidneys, and then that leads their kidneys to not filter appropriately, and then it's spilling a lot of protein in their urine. So they almost start off with steroids as the first thing. So if they respond well to steroids, that's a good indication they're going to be able to control it. And if not, then they have to go more aggressive with their autoimmune treatment. But the one thing that you need to sort of remember about nephrotic syndrome is that it's associated with very, very high amounts of protein in the urine. So since the protein is in the urine, it's not in the blood. So they have low serum protein and high urine protein. And what do you think happens? Like if you don't have enough albumin in your body, are you more or less likely to become edematous?
More.
You're more. So you kind of see edema in these kids because they don't have that oncotic pressure. They don't have that albumin, that protein in their blood to keep their vascular space full of fluid, and it leaks out. So you're going to see high amounts of protein in the urine, and you're going to see the generalized edema. You're going to see the weight gain because of the edema and their kidneys aren't filtering. Sometimes they don't feel good, so bad appetite, not the same energy level. You want to do a close look at their blood pressure since they're, having fluid overload, their blood pressure could go up. So you're going to see massive albumin and in the urine. So this is the, just kind of remember, always, it's high protein in the urine. And they might have some red blood cells, but if you're seeing a lot of red blood cells in the urine, that's something else is going on that you need to be concerned about. And they're a higher risk for infection, in part because of their autoimmune process, and also because a lot of the medication that they take is going to damper down their immune system. So they're frequently on steroids. So the first line treatment is going to be steroids. And then they can add in other medications like diuretics. And then you're also going to be doing some management of diet. You know, they might need fluid restriction and salt restriction, depending on where they are in their treatment process. But since they're prone to fluid overload and edema, sometimes you have to monitor and adjust their salt and fluid intake. So it is important to remember that this is like a chronic illness. This is something that's going to come and go. It's going to be relapsing like many autoimmune diseases. So they're going to need a lot of support. They're going to need a lot of education from the nurses. You're going to do your strict I's and O's, daily weights. And then if they're on autoimmune suppressive, or if they're on immune suppressive medication, or if they're in a flare-up, then they should not get immunized. So you just need to be aware of this. We focus a lot on immunization in pediatrics, but this is a specific population where their immunizations potentially are going to need to be delayed if they're in a flare-up, or if they're on high doses of prednisone. So acute glomerular nephritis, this is another one. We talked about rheumatic fever was related to strep throat. This is another thing that's related to strep throat. So it's an allergic reaction to group A beta hemolytic streptococcal. So that's the bacteria that causes strep throat. So the child gets strep throat and then they have an allergic reaction, and that causes damage to their kidneys. It usually causes damage to both kidneys. There's a wide range of severity. Sometimes they just kind of have like a slight drop in their urine output and they don't feel good for a couple of weeks, and sometimes they end up on dialysis. So there's a pretty wide range of how badly their kidneys are attacked, but usually the autoimmune process kind of runs its course and then their kidneys come back to normal. So kind of in the ballpark of genital urinary, there is a specific tumor that is a tumor of the kidneys. So it's called Wilms tumor. It's otherwise known as a nephroblastoma. So it's one of the more common malignancies of childhood. And sometimes there aren't a lot of symptoms. It's often diagnosed because the parents can feel an abdominal mass. So sometimes it progresses to the point that the parents are able to feel that something's different. And there's something as a nurse, you want to make sure that there's, as a priority, that there's a sign above the bed saying that they don't do any abdominal palpation. You could actually damage the kidney, cause like rupture, if you're in there really pressing on the abdomen. So once they're diagnosed with Wilms tumor, then, no one's going to be just randomly coming in and doing a deep palpation of that child. It does require surgical resection. And because it affects their kidney and their ability to filter things, they can present also with hypertension. So surgery, radiation, chemotherapy, and they, if it's just one kidney, they'll take out the affected kidney. And usually it's just one. It can be two, but it's usually just one. So then it has a pretty good prognosis if they get the kidney out and they get the appropriate chemo and radiation. So hydrocele, this is another thing that only affects boys because it just is a collection of fluid around the testicle. So it makes the scrotum look swollen. Usually, like, I don't know if any of you have seen a newborn baby boy, it's not uncommon that genital area is a little bit swollen. It usually just goes away on its own. But if it still is swollen for more than a year, then they might need to have surgery. So I'm not going to lie to you. I have a very, very hard time saying this word, cryptorchidism. This just is undescended testes. So the testes are still in the abdomen when they're born. So the boys have the penis and they have the scrotum, but the testicles haven't fallen down from the abdomen into the scrotal sac. So it can be unilateral, bilateral. Unilateral is more common. So it's important to pay attention. So when you're, doing a newborn exam, you do want to feel the scrotal sac, because when you feel them, you should be able to feel the testicle inside that sac. So it's important to note if it hasn't descended, because it can cause infertility if the inside of the abdomen is warmer than the outside. So it can affect their ability to produce sperm. Sometimes it's associated with an inguinal hernia. And then even though it affects fertility in terms of sperm production, it doesn't affect secondary sex characteristics. So they'll still develop normally, but you do want to treat it because of the risk of infertility if the testes isn't brought down into the scrotal sac. So they do have a slightly higher risk of testicular tumors, and like I said, the surgery, if it doesn't descend on its own, they can do the surgery to pull it down. So, you want to make sure that you're doing good education, teaching the patients as they grow older that they need to do testicular self-exams. Make sure that you're talking to them and being non-judgmental, because it can be embarrassing that they have to have surgery on their genital area. And it's just the scrotum and the testes. That doesn't have anything to do with their penis. So whenever we're talking about kids, we always have to think about where they are in their growth and their development. So 3 to 6, they're experimenting with their body. It's normal for them to maybe be masturbating, being a little bit curious about their genitals. So you don't want them to really have like a negative reaction if they have to have surgery. So just to kind of think about where they are in their developmental stage and making sure that you can talk to them in a way that's going to make sense to them, so they're not fearful of the fact that they have to have surgery on their private parts. Does anyone have any question about that first PowerPoint? Great. We're going to move on to skin conditions. So I think you guys are aware that, the skin is a very large organ. It covers all of our body. And what do you think? Do kids have skin that's more permeable or less permeable than adults? Do they absorb medications, et cetera, more?
You're breaking up, Professor.
Is that better? Can you give me a thumbs up if you're able to hear me?
Yeah, I think you're good now.
Okay, thank you for letting me know. So do you think that kids, that their skin absorbs more or less? Are they more or less likely to absorb more medication through their skin than an adult?
I believe they do.
They do. Yeah, so their skin, it absorbs more. And they, some other changes or differences is that they don't have the same ability to thermoregulate. So their because their skin still isn't mature. So you're not going to really see mature skin till age 3. So you worry more about the younger kids and in terms of the skin conditions. So you always are going to be paying attention to what the skin color is, the temperature of the skin, if there's a rash, and what the hair distribution on the skin looks like. And if you ever see a rash or a lesion, documentation is everything in nursing. So the size of the lesion, the color, what it looks like, is there pain or itching, is it generalized or localized? All of that should be documented when you're documenting that you see something that's different about the skin. And then trying to make sure that you figure out what's going on so you're not unnecessarily giving them medications. So if there's itching, you don't want to necessarily just put Benadryl on it. You want to know why it's itching before you give them a medication. And then if there's any skin breakdown, you want to make sure that you're, treating appropriately and making sure if they need antibiotics or something that they're on that also. So this next slide here, I know that we're going to go over this again in the communicable diseases. I will just say that you should be able to recognize these terms. These are all different terms that are related to skin rashes. So a macule is flat, kind of like a freckle, and a vesicle is elevated and fluid filled, and a scab is crusty. A papule is something that's elevated like a pimple. A pustule is elevated and it's filled with pus. And a wheal is raised, and you see this kind of like hives or allergic reactions. And then ecchymosis is that blue-purple. So it's always good to know, like if someone comes in and there's a rash on their skin, that you can use the correct medical term to describe what you're seeing. So a stye is just kind of like an inflammation of one of your eyelashes. You'll see it usually on the bottom. And it's, it kind of gets puffy and swollen, and sometimes you need to give them some antibiotics to clean it up. And there's some things that kids can be born with. So a port wine nevus is like a port wine color. They're flat, purple to pink. And there's something else that kids can be born, which is called a strawberry nevus. And the port wine darkens as the child gets older and it doesn't go away. Whereas the strawberry nevus is very common, dilated capillaries, and then it just kind of goes away without any treatment. So both of these can be concerning for parents. They're both usually harmless. If they need to do it, they can do some like phototherapy, because like especially the port wine is a little bit more discoloring and it can be more concerning to parents. So there are some treatments to help it go away. But usually they're harmless, and the strawberry one goes away on its own without any treatment almost always. And then these next two, the cafe au lait and the hypopigmented macules, these are both associated with potential problems that you would need to follow up on. So the cafe au lait are these little light brown oval patches, and they're associated with this neurofibromatosis and tuberous sclerosis. These are both types of tumors that can spread throughout the body. And then the hypopigmented macules, they're also associated with the tuberous sclerosis, which is a widespread tumors throughout the body. So these oval patches, either whitish or light brown, they can be born with them. Sometimes people see them and they think it's signs of abuse. So it's good to recognize them and recognize that they're born with them. It's not a sign of abuse, but they still need a follow-up, because these two are associated with more complications that they would need to see a specialist for. Whereas the port wine and the strawberry nevus, those are just kind of discoloration. They're usually harmless, and they don't necessarily need any treatment. So there's specific type of rashes. So you guys have probably heard of a butterfly rash. So in kids and adults, it's associated with SLE. So this is the rash that kind of goes over the bridge of nose. There's a type of rash that's called a scaling skin eruption. And you see it more on the cheeks and in the perianal kind of diaper area. And it's kind of inflamed and kind of crusty, kind of flaky skin is associated with nutritional deficiencies. And then there's also just, birthmarks. And it is important to remember, document them and see if they're changing over time, et cetera. But, and they can resemble a bruise. So you need to make sure that you're not unnecessarily being suspicious of child abuse. You almost never worry about them, but if they're in the spinal region, there could be something with their spine. And if they're near the chin or the nose, kind of this area here, it could be a problem with their airway. Those are the only two reasons that you would ever really worry about a birthmark. And then we're going to move into some sorts of infections that can cause rashes. So this malaria is common in children. This is this heat rash. So the sweat glands get blocked and they get these little like prickly raised bumps. And they can be itchy. It's usually in areas where they're going to have like extra heat, like diaper area or skin folds. And you just kind of keep the area clean and dry and make sure you're changing their diaper frequently. And this itch or trigo, it sounds bad, but it's just kind of chafing in the skin folds. So bigger kids that have more skin folds are going to be prone to this. They can get like a yeast infection in this area. So you need to make sure that you're kind of keeping the skin folds clean and dry. And then if you see anything that looks like it could be a fungal infection or a yeast infection, that you get them on the appropriate treatment. And this is seborrheic dermatitis. It's just a fancy word for cradle cap. Has anyone heard of cradle cap? Have you had any babies that had cradle cap? So it's just kind of like the yellow. Yeah, someone had a baby with cradle cap.
Me.
Yeah, what did the doctors tell you to do?
Well, because I'm breastfeeding, I used the breast milk, but
Okay.
I got like this cone.
Okay.
And kind of wash it and kind of lift it up instead of like scratching it, because if you scratch it, it kind of takes out your hair.
Right. Okay. So you don't want to rub it too hard. So there's some things they do. Sometimes they recommend putting a little bit of oil on and kind of letting it seep in to the area that's crusty, and then washing their hair in the morning and combing it out. But usually it's just kind of washing their hair and combing it out. It'll get better over time. And sometimes parents don't like it, but it's really not. It's not a big deal. It just kind of doesn't look that pretty, but the baby will get older and it'll get better over time. And then diaper dermatitis, this just is a diaper rash. If it's really, really beefy red, that can be an indication of a candida infection, which is going to require a different sort of treatment than your standard diaper rash. So you really need to make sure that you're changing them on a regular basis. And then if you can air them out, one of the things that we recommend is that you tape the diaper off and let their butt just kind of be exposed to air for a little while. And then if they do develop it, you get them on an appropriate treatment for the rash. Acne, I think you guys all know what acne is. This is going to be more common in the teenagers. You can get it in younger kids. You do a lot of, exfoliation, cleaning, diet, sleep can all help with acne. And then you can get herpes type 1, which is going to be like a cold sore or a fever blister. If it commonly happens, they can be on antiviral medication. They just have a home that if they feel it coming on, they can start to take their valcyclovir. And sometimes kids will be under stress, or they'll be getting sick or getting their period, and then the fever blister will happen. Babies can also get eczema. So does anyone know, if you have eczema, what are you more likely to develop later in life that's not at all related to your skin?
Is it on the elbows?
Asthma. Yeah.
Oh, asthma.
Asthma, yeah. So eczema tends to be like a hypersensitivity reaction. They tend to have allergies, and they are more likely to develop asthma. So sometimes they can
I was
have.
confused with psoriasis.
Oh, okay, yeah. I'm glad you're paying attention, Walter. So if they have eczema, you don't want them exposed to somebody that has like a herpes outbreak because they can end up getting the eczema infected. Sometimes they'll flare up after immunizations, and like I said, it is associated with inflammation. So sometimes they'll have these elevated IgE levels. And you do need to kind of pay attention and keep up on it because the skin is broken, they're at risk for getting either a viral or bacterial infection in that spot. So, you know, you want to treat the symptoms. So alleviate the itching, keep the skin hydrated, prevent infection. And there's a series of different medications, that corticosteroids, antibiotics, and the anti-itch medication. So it's a lot of symptom management. And then you can add some oil to the bath water to help keep their skin nice and hydrated. And sometimes this oatmeal bath can help with itching.
Mhm.
So you want to, if you're going to be teaching the parents, you know, it's best to like make sure that you're wiping off the medication between treatments. It's actually best to have them take a bath and then put the medication on after the bath. And you know, the cortisone creams help with the itching a lot, but it is a steroid that can be absorbed into their body. So this should be kind of their last resort. They shouldn't be using the cortisone cream when they don't need to. And you want to keep the nails short and kind of prevent the kid from scratching and itching a lot. So staphylococcal is a common bacteria on our skin. So it can cause skin infections around the umbilicus or around a circumcision. So this is like not, you know, if a circumcision area or the umbilical area were to get infected, it would probably be a staphylococcal, which is the bacteria that's already living there. It can make them quite sick. They can end up with sepsis. So you need to pay attention. So any small little pustules, like little raised bumps that have pus on the inside, you should report immediately because that could be an indication that they have a staphylococcal infection. And then they will need to be treated with antibiotics, and MRSA is always possible because a lot of the communities have MRSA out there. So any sort of staphylococcal infection could be a MRSA infection. So scalded skin syndrome is also a bacterial infection called by Staph aureus, and it causes like this kind of reddish hue to the skin, and it has like they call it a sandpaper texture. So fine little bumps, and when you touch it, it feels like the skin feels like sandpaper. And it, you know, even though it has all these fine bumps, you know, when they're treated appropriately, it heals up without scarring. But they do, if they have, you know, the Staph aureus infection, it does need to be treated with antibiotics. So impetigo, you'll see this. Has anyone ever had a kid that had impetigo? If they were in daycare? Have you heard of it before?
I know it's an infection.
It is an infection, and this is the one that is always described as having like honey colored crusts. So it's on their skin and it kind of has this yellowish, goldish, crusty color. The vesicles kind of break open and it leaves like this crusty yellow goo wherever the infection is. It's super contagious. It spreads very easily between kids, and they do need to be treated with antibiotics. They generally recommend that you gently wipe off the honey crust because that fluid is infectious. So they recommend that you kind of wipe it off and that you treat them with antibiotics. So fungal infections, you can get hair and nails. You can also get, you know, on your feet. You can get it in your genital area, like a jock itch. So if it is fungal, then it needs to be treated with an antifungal cream. Usually is where they start, but if it's in the hair and nails, they might need to take like an oral pill. So pediculosis is just the medical term for lice. So the more common is going to be head lice, but you can also have body lice, and then you can have lice in your genital area. And it is something that's also very infectious, and you need to be getting rid of the nits and then treating with an appropriate chemical to kill the lice. Scabies. Scabies is also quite contagious, and you see little areas. Usually you'll see it on their hands or their feet, where you see little lines running up between their fingers or running up their legs, and the mites burrow under the skin and they lay eggs. And so those little lines that you see is a little burrowing of the mite. So you need to treat it with a very specific medication called permethrin. And you need to treat everyone in the family and like clean everything really well because it's highly, highly contagious. So those are all of the infectious and things that they can be born with. Obviously, when we're talking about skin, they could have burn injuries. And it is, a significant issue. Is the leading cause of accidental death between 1 and 4 years. So a lot of kids, unfortunately, are burned. It can be child abuse or neglect, or it cannot be. So making sure you're doing a lot of anticipatory education and helping parents understand how important it is that they're not around like stoves or hot liquid or even hot water. So we always think of it as being heat, but it can also be chemical, electrical, or radiation. So there's different ways that people can suffer burns. So you always worry a lot. So if you're ever given a priority question, and if someone was burned around their nose and mouth, what do you think your priority nursing intervention is going to be?
Their airway.
Their airway. So whenever there's been any damage to their nose and their mucous membranes or the oral membranes of their mouth, you really have to make sure that you're paying attention to whether or not their airway is safe. We talk about, body surface area in terms of how much of the body is burned. You should be familiar with the phrase, the rule of nines, in terms of what percentage of the body. You're frequently going to document when someone comes in. The rule of nines, it works really well for adults. Kids, their body proportion changes over time. So this kind of gives you a breakdown of size estimation based on age. So I think that you should remember the rule of nines is like your basic rule to estimate body surface area, but then also remember that kids, like when they're little, they're kind of short and squatty, and then they grow taller, so that the rule nines doesn't really work until they're over 10 kilos. So when you're talking about a younger child or a baby, you might need to be just kind of pulling up a reference chart to really think about how much of their body surface area, because their proportions change over time. So someone said at the beginning of class that the skin absorbs more, it's thinner. So they're more prone to burns because their skin isn't mature yet. And because of their, they have a larger body surface area to their mass and the thinness of their skin, they're more likely to have complications like food and electrolyte problems, and they can lose a lot of protein, and they need more calories. So, when you're recovering from a burn, you need a lot of nutritional support to help rebuild the tissue that's been damaged. So specifically, you need more protein and calories. So these are some more differences between kids and adults. So they have, less muscle and fat. So that makes part of what makes them more susceptible to complications. And then they are also more likely to have scar formation because their skin is more elastic. Things to think about: they don't have a fully mature immune system, and also growth and development. Sometimes you're in the hospital a long time after a burn, then that can really impact their growth and development if they're stuck on a hospital bed. So you should be able to think about, what is a moderate versus a major burn. So a moderate partial thickness for 15 to 30% of the body, or full thickness for less than 10%. And then that's a moderate burn. And then a major partial thickness for 30% or more, or full thickness for 10% or more. So just to remember that it can be a major burn, even if it's partial thickness, if it's a really large percentage, 30% or more. And that, their risk for infection or complications has to do with whether it's moderate or major. I don't think that slide is useful. So, electrical, this would be like an electrical cord or something like that. You need to make sure that you know where the electricity entered and left the body. And then just remember, it's like traveling through the body, so you can have more muscle damage. So in terms of the burn, what you do when they come in, so stop the burning process. So, you know, if it's a hand that's burned, you can put the hand in some cool water so that it's, you know, it's no longer being able to transmit heat. You want to cover the injury and then get them to the nearest hospital. And then one of you mentioned this, I think it was Miss Trinata, emergency care, anything around their face, you're always going to be making sure they have a secure airway. They're also going to need an IV line. They have lots of fluid and electrolyte problems. Making sure you have blood available. They may need to have a nasogastric tube to drain their stomach contents, etc. Just to always remember that wound care can be really painful. They're going to need really good pain control. They're normally going to be taken to a burn center that specializes in burns. And they're a very high risk for infection and fluid loss and electrolyte shifts because of how much of, because of this fact that the skin is damaged. Making sure that you're using sterile equipment, protective isolation, thinking of all those things to protect the child. So remembering that they're going to have fluid shifts, so you have to be paying attention to both, you know, dehydration and the risk of fluid overload, that they are going to need higher protein, higher calories, additional vitamins and minerals. It takes a lot to heal from burns. Contractures, this is going to be positioning so they are able to move their hands and feet, et cetera, once they've recovered, and that it's a long process. They're going to need a lot of emotional support. So those are burns, and then sunburns as usually not nearly as bad as like a burn from hot water, et cetera. So, but a lot of it's the same sort of treatment. So you're gonna get them out of the sun, put something cool on there, and then rehydrate the skin. You wanna make sure they're using sunblock, and the sunblock that has zinc oxide or titanium dioxide are more effective. And then it says hydrate the skin. Do you guys think that you put things like petroleum jelly on sunburns? No, so you don't want to like trap the heat in there. So you want to cool it off and then put something on there that can be absorbed, but you don't want to put like an oily, greasy thing that just kind of sits on top of the skin and traps the heat.
So like aloe. Aloe
is good, yes. On the other extreme, frostbite is exposure to cold for too long. If their whole body's been exposed, like it could be just that they didn't have good shoes and so their feet were exposed, but if the whole body exposed, you're going to focus on warming up the head and torso first. And your worst case scenario, you can end up with necrosis or just tissue death, and they can require amputation. In the modern area, that level of frostbite is very unusual, but you know, they could have like been in a car accident and left outside without access to warm clothes for an extended period of time. So it can happen. Does anyone have any questions about the skin pieces? Okay, we're gonna do a quick Kahoot and then we'll pick back up. Do you guys want to take a break now and then come back and take the Kahoot, or are you guys feeling up to log into, you know, carrying on?
It doesn't matter to me.
Doesn't matter? Okay. If you guys don't care, we'll go ahead and do it. And then I think we'll probably just take a brief break so that we can stretch our legs. Okay, we'll go ahead and get started here. So when a parent asks about correcting the hypospadias of a newborn, what is the nurse's best response? No intervention is necessary as the defect will correct itself over time. Surgical repair is needed, usually performed before 18 months. Repairing the defect will increase the risk of testicular cancer, or corrective surgery is usually delayed until preschool. Yeah, so this is the one where they don't circumcise them right away, and they use that foreskin for the surgical repair, and they usually do it before they're 18 months old. So the mother of a 5-year-old taking prednisone for nephrotic syndrome asks about immunizations. What is the nurse's best response? The child needs to take antibiotics in addition to getting his shots. Vaccine interfere with the treatment of nephrosis. The immunization should be delayed, or the vaccine should be given in smaller divided doses. Right. So if they're in a flare up and they're taking prednisone, then they do need to have their immunizations delayed. So this is something that you're going to need to coordinate with their primary care provider so that you can time the immunizations when they're not taking a medication that tampers their immune system. So which physical assessment technique will the nurse omit when caring for a 2-year-old with Wilms tumor? Palpating the abdomen, assessing for bowel sounds, range of motion exercises on the lower extremities, or percussing ankle and knee reflexes. Right. So this is palpating the abdomen. There should be a sign at their bed that they don't have any abdominal palpation, because you can actually rupture the kidney, cause damage if they have the Wilms tumor. So a 6-year-old child with daytime enuresis complains of dysuria and urgency. The nurse recognizes this may indicate what? Vesicular urethral reflux, nephrotic syndrome, acute glomerular nephritis, or a urinary tract infection. Right, so this is going to be your urinary tract infection. The nephrotic syndrome, this is the one that's specifically associated with a lot of protein in the urine. So a 5-year-old boy is admitted to the hospital with acute glomerular nephritis. What is the probable cause? Recovery from German measles, a sore throat 2 weeks ago, a history of food allergies, or a recent urinary tract infection. Right, so this is the one, acute glomerular nephritis is an allergic reaction to a strep infection. So this is the one that's specifically associated with group A hemolytic strep, which causes strep throat. So more likely he had a sore throat a few weeks ago. How is infant skin different than adult skin? It's thicker, it has greater absorption, it has fewer sweat glands, or a smaller body surface area. So good. Yeah, there's greater absorption, and they have a larger body surface area to their mass, and it's thinner. So you have to be thinking about that when you're prescribing medications and thinking about their absorption of the medications. So a child has sustained a 2nd-degree deep thermal burn to the hand. What is the best first action to take? Immerse the burned area in cold water, apply petroleum jelly, break any blisters, or apply ice. Right. So you're going to do cold water. Ice would be too cold, but you want to cool the area off. You're not going to put something like petroleum jelly that really traps the heat in there, and you're going to leave the blisters intact. They'll rupture over time, but if you break them, you're more likely to have scarring underneath the blister. What would help the child with a serious burn meet nutritional needs during the recovery phase? Increase calories and protein, increase fat, decrease carbohydrates, or decrease calories because they're going to be on bed rest. So good. Yeah, this is the one. They need more calories and protein when they're recovering from a burn. Oh, Reese. Parents asked the nurse about the red area on an infant's neck that appeared a few weeks after birth. What do you think it is? A port wine nevus, intertrigo, a strawberry nevus, or impetigo? So it's more likely a strawberry nevus. The port wine is going to be there at birth, and you'll see the strawberry nevus a few weeks after. So a child is brought to the emergency department with burns on the face and chest. What is the nurse's first priority? Assess respiratory status, insert a Foley catheter, remove clothing, or administer pain medication. Very good. This is the face. You're always going to be worried about respiratory status. Last one. So what should the nurse stress to the mother of a child with impetigo? Small crusts and bites should be treated promptly. The crusts on the lesion should be left in place. The lesions may spread, but it's not contagious, or the condition is caused by herpes simplex virus type 1. So you do worry about secondary infections. So the small cuts and bites should be treated promptly. Then the yellow one, the crusts on the lesion should be left in place. You actually recommend that you kind of gently wash those off. It's very contagious, and it's a bacterial infection. It's not caused by the herpes simplex virus.
Mm.
All right, good job, you guys. So I'll put the Kahoots in the announcement after class. I'm going to suggest we just take a 5-minute break, and then we'll come back and do the last 2 chapters, and then you'll take your second Kahoot. Okay, so you see you guys at 10:05. Okay, thanks for coming back, everyone. So we're going to do the communicable disease chapter first because I know the quiz is pretty heavily focused on the endocrine chapter. So I want to do the endocrine chapter and then your Kahoot so that you guys have the information that you need for the quiz fresh in your mind. I probably am not going to go over all of the PowerPoint slides in this communicable disease section because I'm going to focus on pointing out the things that I know that are most important for you to do well on your quiz and your test. So I think you guys have talked about communicable disease a fair amount throughout nursing school in terms of thinking like the spread of infection, how to stop the spread of infection, importance of hand hygiene, different types of isolation, etc. So I would just point out that you need to be thinking about all of those things when you go into your quiz number 3, thinking about what types of isolation, I'm sorry, not quiz number 3, your exam number 3, when you're thinking about different types of isolation for different diseases, etc. Generally speaking, when we're talking about communicable diseases, we're talking about the spread of diseases, and then we're also talking about the use of immunizations to help prevent the spread of communicable diseases. There are certain things that have never really gone away. So HIV, hepatitis, tuberculosis, and sexually transmitted infections, they are still kind of occurring in all communities throughout the world, and we need to be aware of that and monitoring for them as healthcare providers. So there's some very general terms that you need to know. So a communicable disease is a disease that can be transmitted from one person to another. The incubation period is the time between the patient's exposure to a disease and the onset of symptoms. So sometimes they can actually be infected and they don't have a runny nose yet, for example. And then the prodromal period is the time between the earliest symptom and the appearance of a rash or a fever. So sometimes, the earliest symptom might be a runny nose, and then 4 days later they have a fever. So that period in between the runny nose and the fever is going to be the prodromal period. And vector just refers to whatever pathogen, animal, insect, etc., is carrying the disease. So sometimes it's just a bacteria, so there's not necessarily a vector, but if it is like caused by a mosquito bite or an animal bite, then the vector is the animal that was carrying the disease. And these are some other terms. I think we've all just survived a pandemic, so we're pretty familiar. Pandemic is worldwide high incidence of a communicable disease. And an epidemic is a sudden increase in disease in a localized area. So if the disease is not spread worldwide, it's just say in China, then that's an epidemic. And an endemic with a D is like the disease is just part of the community. So it's like we're probably moving into an era where coronavirus is going to be endemic, where it's not really causing a lot of infections, but it's out there still in the community. And an opportunistic infection is an infection that occurs in an immune compromised host. So for example, somebody who has HIV and their immune system isn't normal, organisms that don't cause other people to get sick that are in the environment can cause a severe illness in someone who's immunosuppressed, and that type of infection is called an opportunistic infection. And then a healthcare associated infection, this would be like an infection you get in the hospital, a ventilator associated pneumonia, or someone that gets a urinary tract infection from having their Foley catheter left in so long. These are healthcare associated infections. Your ability to get sick from an infection is going to depend on a lot of different things: your age, your gender, how healthy you are, your nutritional status, your genetic makeup, your mental health, how intact your skin is, how intact your immune system is. So there's lots of different things that influence what we call the virulence. The virulence is how sick an infection will make you. So this is something that I do want you to focus on this slide here, because I know you're going to be asked different types of immunity. So acquired immunity is either you had the disease or you got a vaccine. So if you had the flu and then you develop antibodies against the flu, that's acquired immunity. It's also acquired immunity if you get the flu shot and then you have antibodies against the flu. Whereas Passive immunity is going to be you have antibodies because they were given to you. So this sort of immunity could be like giving somebody IVIG, which is antibodies, or like breast milk gives passive immunity, where the antibodies pass from the mom to the baby. So passive immunity doesn't last as long as active or acquired immunity. So you're giving somebody antibodies, but the body hasn't produced their own antibodies, so it doesn't last as long. And then active immunity is your immune system is producing antibodies to an infection. So I would remember these, and I would remember, what type of immunity do you have after you get a vaccine? So there can be direct or indirect transmission of an infection. I think we all know that. Let's see here. I want to make sure I point out the most important things for you. So you guys need to be thinking about, treating patients in the hospital or in a clinic. This is aseptic technique is you're going to use it with all patients. This is your universal precautions. And then your standard precautions is like your hand hygiene, use of appropriate personal protective equipment. So just always be thinking about what type of isolation the patient needs, how to protect yourself, and how do you protect the patient and other patients. And then airborne, what sorts of patients are put into airborne precautions? Have you guys ever had a patient on airborne precautions in the hospital?
Would it be
Yep,
like
Walter.
TB?
TB, very good. So this is going to be like a reverse airflow. So they have to be in a special room. You have to wear one of those N95 masks. The most common thing is going to be TB, that you're going to put them in airborne precautions. So, always trying to put, if you have to room patients, that put similar infections together and not put like someone that has RSV with someone that has a skin infection. Making sure that you're, taking your gowns and gloves off appropriately, making sure that you're doing appropriate hand hygiene. Droplet precautions, what sorts of patients would be in a droplet precaution? Do you think someone that had influenza would be in droplet? Influenza, RSV. So think about, infections that spread with the droplets to come out of your respiratory system, and those patients need to be on droplet. Sometimes you do protective isolation. So like a patient that's had bone marrow transplant or they're on immunosuppressive therapy, you want to make extra cautious that you're not bringing them any infections. So then you put them in protective isolation. Often there is hand hygiene, that gel outside of the rooms. And so you should always be gelling in before you go into any room. There is a very specific infection called C. diff though, that if they have C. diff, you really need to be washing their hands. You should not be using the hand sanitizer if you're taking care of a patient that has C. diff, and not just because it doesn't get rid of the infection and then you could spread it. C. diff is highly, highly contagious. This is pointing this out that, you should be making sure that you're actually doing good hand washing and not using the hand-based alcohol gel for C. diff. So you do a lot of education as a nurse about hand hygiene, making sure kids are getting their immunizations, food storage, cooking meat appropriately, cleaning towels, not having insects in the home, and avoid uses of sandbox in the yard. Why do you think that you want to avoid sandboxes in your yard? Who might get into a sandbox?
Cats.
Cats. So cat poop can make kids sick also. So this is, I told you when we talked about the skin, this is another slide that goes over the different types of terms that you will use to describe a rash on the skin. So I would, the other slide had the pictures. I would be able to point out, a papule is a circular reddened area that is elevated, where a pustule is a reddened area that's elevated and contains pus. So I would pay attention to this slide and the different words and be able to differentiate between the different terms. So, you know, we protect against communicable diseases by massive immunizations. I would, you know, just be aware that that is like our main thing that we can do in public health to stop the spread of communicable diseases. In addition to immunizations, which are going to be your vaccines, there's other things that we can inject. So like immune globulin is going to be something like IVIG that gives people passive immunity because you're giving them antibodies. You can also give them, you know, specific immune globulins or antitoxins. So just to remember that, you know, vaccine is going to be the most common type of immunizations, but there's other things that we can inject into people that help stop the spread or help people's immune system. So you're going to do a lot of, if you ever work in outpatient pediatrics, you're going to be doing a lot of immunizations. They have to be stored at a very specific temperature. You need to give patients or their parents like the vaccine information sheet with every vaccine. They need to consent. I do know there will be some questions in your future about vaccines. So there's a couple that you don't do in infancy. Who knows the vaccines that you normally give before they start school, but you're not going to give them as an infant? There's two.
Is it varicella?
Varicella is one of them. Very good. And there's another one that you don't give right when they're young.
Is it the measles, mumps, and rubella? Because
It
it's live.
is. Yes. So the varicella and the MMR, you're not going to give to infants. So the other ones you really are, and you start around 2 months old, but you should definitely remember that the MMR and the varicella, those are a little bit later. It's before they start kindergarten, but you're not going to give them when their immune system is still immature. Like you said, they are both live vaccines. So this is another one. Those two, you're also definitely going to wait if they're taking any sort of prednisone or any sorts of medications that alter their immune system. So emergency preparedness is, I would kind of recognize the term, you know, we're now living in a world where we could have terrorism attacks or something like that. So, you know, if you're working in some sort of an environment like a hospital, your hospital is probably going to have an emergency preparedness policy. So to be aware that those things exist, and that unfortunately we live in a world where something like that could happen. So that is all I'm going to go over in terms of the rest of this slide. Just because I am aware of what is out there in terms of your quiz and your exam 3, and I want to make sure that I go over all the information that you need to know for your quiz today. So does anyone have any questions on what we talked about so far? Okay, I'm going to go ahead. This next PowerPoint, it's a lot of information, but it's really important information. So this is going to be the child with a metabolic condition. We're going to be talking about like diabetes, different endocrine problems. And I know that this is going to be something that you're tested on. So when we're talking about metabolic, we're talking about hormones and enzymes, which are secreted from glands. So they're secreted from glands all over your body. So just to kind of remember, this is going to be, you know, a chapter that covers a lot of different problems, but they're all related to substances that are secreted by your glands. So hormones are produced by your glands, they are secreted directly into your bloodstream, and then there'll be like a target organ. So that is the organ that the hormone works on. And if you don't have enough or you have too much of a certain hormone, both of those things result in disease. So an example of enough or too little. So if you have not enough thyroid stimulating hormone or too much thyroid stimulating hormone, both of those things result in disease. So you can also have a problem where you don't produce an enzyme. So you need enzymes to break down different particles. So if you have an inborn error of metabolism, that means you're not producing a specific enzyme that you need. for example, to break down what you eat. So if you have an inborn error of metabolism, you're going to be generally sick, not feed well, not gain weight well. A lot of inborn errors of metabolism are diagnosed in the newborn period, and frequently they're on newborn screens. So you do need to be paying attention, even though most inborn errors of metabolism and a lot of the endocrine problems are going to be on newborn screening. Things can always be missed. So if kids are not growing or developing normally, you need to have on your differential diagnosis that it could be a metabolic problem. So you're going to do, once you start being concerned that it could be a metabolic problem, you're going to have to be thinking about what different tests you could do. So there are some screening tests like PKU and chromosomal studies are ways to look for inborn errors of metabolism or chromosomal abnormalities. You might need to do a tissue biopsy or look at thyroid function. So it's not going to be one specific test because metabolic encompasses a lot of different disease processes. So you have to be thinking about what's wrong with the kid, what might be causing it, and then how you would evaluate it. So there's a lot of different tests that could be involved in diagnosing somebody with an endocrine problem. So there's a couple, this one here, PKU is an inborn error of metabolism. This is another one, Tay-Sachs. So these are both where they're missing an enzyme that they need. So when they have Tay-Sachs, they're missing an enzyme and they can't break down lipid deposits. So then lipid ends up accumulating on their nerve cells and it causes progressive mental retardation. So this is going to be something that's specifically in the Ashkenazi Jewish population, and it is a genetically inherited inborn error of metabolism. So I would recognize that PKU and then Tay-Sachs, these are probably the two most common inborn errors of metabolism. And an inborn error of metabolism is missing an enzyme that you need to break down something in your body. So this is more information on Tay-Sachs. There is no cure. For PKU, you can give them food that they're able to digest. So they're missing an enzyme that they need to break down part of their food. But if you give them a very specific diet, then it can be treated and they can live a normal life. But with Tay-Sachs, there is no treatment, there is no cure. It's just a progressive condition that ultimately results in mental retardation. They almost always die before the age of 5. And so it's just palliative care. But if a child is born with Tay-Sachs, then those family members need to be tested because it is a genetically inherited disorder. So, and then endocrine is going to be specific related to hormones. So I think you guys, if you've done like med-surg or you've been around adults, there are a lot of adults out there that have hypothyroidism, in which case they take Synthroid or a thyroid replacement. So you can be born with hypothyroidism or you can have it in childhood. Hypothyroidism and type 1 diabetes are the two most common endocrine disorders of childhood, with hypothyroidism being the second and diabetes mellitus being the first. So hypothyroidism is on newborn screens, but it's something that you just always have to remember because untreated hypothyroidism is something else that can lead to mental retardation. So this is something that's treatable. They can get their thyroid hormones replaced and then they can live a normal life. But if they're not diagnosed and they're not treated, then it can lead to mental retardation. So what do you think a baby with hypothyroidism, how would that baby, what types of symptoms would that baby have? They're not producing enough thyroid hormone. Would they be really irritable or really sleepy?
Sleepy.
What do you think? Sleepy. So when you see hypo, think less, lower. So they're sleepy, they don't eat well, they're kind of cold, they don't have very good muscle tone. And then their tongue can become enlarged. So they tend to have noisy breathing. So a baby that sleeps a lot, snores, isn't able to eat well and it's kind of floppy, this would be your baby that you would be concerned about. Hypothyroidism, so the hypo, like less, so they're not as active, they're more sluggish. And then the opposite, how about hyperthyroidism? What do you think a baby with hyperthyroidism would act like? If hypo is sleepy, what would hypo be?
Restless.
Restless, irritable, jittery, they might have a fever. Okay, good. So hypo is going to be treated with medication. They give it. You're most likely to see hyperthyroidism if they've had a medication overdose. So you need to recognize the signs of hyperthyroidism, because it could be a sign that they're getting too much of their medication. It's very unusual to have hyperthyroidism by itself, but you can be an indication that they're taking too much of their medication that's being used to treat hypothyroidism. So jittery, anxious, maybe a higher temperature, higher heart rate, they might sweat more. Everything is kind of more riled up when they're when they have hyperthyroidism. But it's not necessarily associated with things like vomiting. It's just kind of they're jittery and irritable and sweaty and hot and high heart rate, but not necessarily something like vomiting. And then the most common, most common is diabetes mellitus. So diabetes insipidus is another endocrine problem. Has anyone heard of diabetes insipidus? Yeah. What do you associate with diabetes insipidus?
Isn't that when you go to the bathroom frequently?
Yeah, so this is like very, very brisk urine output. So it happens in patients that have a brain injury. Sometimes you'll see DI after a brain injury, or it can be a problem where they're just not secreting enough antidiuretic hormone. So, but it's a problem with their pituitary gland. And you can put pressure on the pituitary gland when they have increased pressure in their brain. So sometimes you'll see it after a brain injury. So diabetes insipidus is going to be very, very, very brisk, excessive urine output. And there's other hormones that are also produced by the pituitary, but the one that I want you to focus on is the antidiuretic, because this is going to be what you're tested on the most. So the decreased from your posterior pituitary, decreased antidiuretic hormone causes diabetes insipidus, whereas increased causes SIADH, which is syndrome of inappropriate antidiuretic hormone. So these are really the opposite. So diabetes insipidus, you pee way too much, and SIDH, you don't pee enough. So they're a problem with the same hormone, but one of them is like you don't produce enough, and the other one is you produce too much. And one's associated with very, very brisk urine output, and one's associated with a decrease in urine output. So this next slide here, I'm going to just tell you that I don't think you really need to know these, but these are going to be other hormones or other endocrine problems. But I know this slide number 17 is going to be the one where you're going to be tested more in terms of the name of the hormone and what it does. So diabetes mellitus is going to be the most common endocrine disorder of childhood. And who can summarize what diabetes mellitus is? Type 1. What's going on in your body if you have diabetes? Is your blood sugar high or low?
Your body's not producing?
Secreting insulin like it should.
Yeah, right. So you're not producing insulin like it should for type 1. And as a result, you're not able to get glucose into your cells, so you have high glucose. So, and there's something called ketonuria or ketosis. So the normal process is your pancreas produces insulin. That insulin then brings glucose into your cells that are used for energy. So if that doesn't happen, if you don't have enough insulin circulating, then your body breaks down fat for energy, and that results in ketones building up. So ketosis is like a sign of diabetes mellitus. It's because this is happening because your body does not have enough insulin and you're not able to use sugar as energy. So if this keeps happening, they develop something called diabetic ketoacidosis. Has anyone heard of diabetic ketoacidosis, otherwise known as DKA?
Mhm.
What do you think someone is like if they come in with DKA? How do they feel? What are they like? Are they sick? Yeah. So they can have altered consciousness. They can have a coma. They could have seizures. Someone that actually goes into DKA can be very, very sick. They're very acidotic. So it's diabetic ketoacidosis, and it all is related to breaking down fats instead of getting glucose into the cell, and that breakdown of fats results in an accumulation of ketones. So hyperglycemia, diabetic ketoacidosis are something that can have kind of in the short term if they're not getting the insulin that they need. But if somebody has diabetes over time and they're not getting adequate treatment, they can develop blindness, circulatory problems, kidney disease, and neuropathy. So there are long-term complications for diabetes. You see this more often in adults than in kids. And then someone, you guys were quite accurate. You said it's not enough insulin. So that's definitely type 1. And then type 2 is something called insulin resistance. So their cells don't really respond to insulin. And also they have more cells, because this type 2 is going to be your big kids, your kids that are bordering obese or obese. So then they have a problem with insulin resistance. So there is a difference between type 1 and type 2. Which one is more likely to be treated with oral medications, type 1 or type
2? Type 2.
Type 2. So type 1 is going to be, they're going to need insulin injections, or they're going to have an insulin pump. But type 2, they can take oral medications. And then gestational diabetes is a transient diabetes that it is in pregnancy. And then you do need to know this. It says other genetic defects. So defects in chromosomes 6, 7, 12, and 20 cause genetic disorders that are associated with diabetes mellitus. So you need to remember these 4 chromosomes and know that they are associated, defects in those chromosomes are associated with diabetes. And I would point out, there's a lot, chromosome 21, Down syndrome is not on this list. Down syndrome causes a lot of problems, but it's not specifically associated with diabetes mellitus. So there's specific criteria for diagnosing diabetes. So they need to have a fasting glucose, so nothing to eat or drink for 8 hours, and then have a glucose level of greater than 126. And then there's the 2 types, type 1, where they don't produce enough insulin, and then type 2, they have insulin resistance. And this is more likely to be in somebody who has a sedentary lifestyle and is obese. So like I said, it's the most common metabolic disorder in childhood. And there's certain things about kids that make it harder to manage their growth. They tend to grow in spurts, and then they level off and they spurt again. They have varying energy expenditure. They like to eat fast food. They don't always want to eat the specific diet. So it makes it a little bit harder to manage than in an adult. And sometimes they're not diagnosed until they end up developing ketones, etc. So what do you think the common presenting symptoms of undiagnosed type 1 diabetes? What are you going to see in a kid?
Thirst.
Thirst. So there's 3 polys.
3 Ps.
Yeah.
Frequent urination.
Polyuria.
And
polydipsia,
excessive hunger.
polyphagia.
Yeah, very good. So polyuria, polydipsia, and polyphagia. So there's the 3 Ps. So whereas diabetes insipidus, there's 2 Ps. What do you think the 2 Ps are for diabetes insipidus?
Polyuria and polyphagia.
Polyuria and polydipsia. So really, really thirsty because they're losing so much fluid and then really peeing a lot. Whereas diabetes type 1 is the 3 Ps. And here you go. You guys got them all. So sometimes it can be like an insidious, they kind of have it for a while before they're really diagnosed. They might be losing weight, be weak. So just to be on the lookout for it. A lot of times it occurs in families, but sometimes you'll get a kid that doesn't have, a family history of type 1 and they'll have it. This goes into a little bit more, you expect to see hyperglycemia because they're not able to bring the insulin into their cells. And they use fat and protein for energy, which is how they end up with the ketosis. And then their inability to bring glucose into the cells, that's why they have that polyphagia or that just desire to eat a lot. So they're always going to be started on insulin. This is one they're going to need insulin. They can't take oral meds. And it's going to be a long-term disease. So it requires a lot of parent education also, but also then keeping the child informed and teaching them things because you need to have them be knowledgeable about it. So over time, they can learn to manage it themselves. We talked about it has to be 126 twice when they're fasting. And then you'll do, the hemoglobin A1C. You've probably heard of that in your kind of your med surge. It kind of gives you a snapshot of what their glucose control has been over the past several months. Our goal is 6 to 9, above 12 is poor control. So this it doesn't give you like a specific glucose number that day, but it tells you how hyper or hypoglycemic they've been over the past 3 to 6 months. So diabetic ketoacidosis, this is they're sick. Sometimes they can actually go into a coma. And sometimes kids are not diagnosed with diabetes until they go into diabetic ketoacidosis or DKA. So, it's a process that happens over time, and it's a result of not having insulin to the point that they're breaking down their fat and their protein as an energy source that then leads to the buildup of ketones, which causes a severe acidosis. So ketonuria. So what do you guys think? What does ketonuria mean? Where are the ketones? Where are you detecting them?
In the urine.
In the urine. So you can do a urine dip strip to see if there's ketones. And they're very acidotic. So it's going to be a low pH. They have this hypertonic dehydration we talked about last week, making sure that you're targeting your IV fluid to their type of dehydration. You'll be able to smell like a fruity odor on their breath. It's not uncommon for them to have an altered level of consciousness and to be nauseous. So it can be mild to severe. They can be just kind of not feeling well to all the way into a coma. But it's always associated with, acidosis and a high level of ketones. So your overall goal when you have a child with diabetes is to make sure they have as normal life as possible, providing lots of support to the family and the child, making sure they have the optimal growth and development. There's certain things about kids that you need to be thinking about. So for example, kids like to play sports. And when you exercise, that can change your blood sugar levels. You want to make sure that kids are eating and then having some time for the food to digest and then playing their sport. You don't want them to ever skip meals before they play sports. You want to make sure they have like backup supplies of glucose if they're playing sports. So if they start feeling jittery or lightheaded, they have some sugar to chew on. Something else to think about is that, for Orthodox Jewish people, they don't take any pork products, and a lot of insulin is pork based. So they might need a specific type of insulin as like cultural sensitivity if they're an Orthodox Jewish family. And we kind of went over this. There's things about kids that make it harder for them to manage their disease. Their growth that kind of starts and stops, and they don't like to eat healthy food. Sometimes it can be embarrassing. So as they're a teenager, sometimes they don't want to give their medication because they don't want to be different than their peers. So there's lots of things about, children and adolescents that make it a little bit more difficult to manage diabetes. Some basic sort of things to always think about for all patients, that it's better to have a well-balanced diet. Sometimes they'll say things like, well, I'm just going to eat ice cream because I know I can give myself some more insulin. So you don't want to get them in that habit where they're injecting more insulin to compensate for the fact they ate a bunch of carbohydrates. So just really a well-balanced diet is your best approach. Very, very precise insulin administration, and then regular exercise. When they don't exercise and then they exercise really hard, that can drop their blood sugar level. So consistent, regular exercise is much safer than this kind of sporadic exercise. So you want to, in terms of the diabetes education, is all about, making sure they're getting the exact amount of insulin that they need, making sure they know how to monitor their blood glucose, then also thinking about all the different things that can go wrong. So skincare and foot care, injection sites, it can be emotionally traumatizing for them. Make sure they know how to check their urine, have a plan for if they travel. If they have illness or surgery, illness can make you more likely to become hyperglycemic. They're going to need to make sure they have a good endocrinologist and a primary care provider for their follow-up care. So think about them as like the whole patient and their family, all the different complications of diabetes, and making sure you're addressing all of those things. So, they almost always are going to be working with an endocrinologist, and it's going to be, a very specific plan of care specific to that family in terms of what they eat and what sorts of insulin management they're going to do. It's going to be generally based on carbohydrate counting, and they're going to give a certain amount of insulin based on how many carbohydrates they're consuming. But always remembering that you want to do your much individualized care as possible in terms of taking into their ethnic and cultural considerations. So dietary fiber is something that helps with diabetes. So if you have a diet high in dietary fiber, it slows how quickly glucose gets absorbed into the bloodstream from your GI tract. So they're less likely to have these super high peaks of blood glucose if they're eating a diet that's high in soluble fiber. And then it also is good for your cholesterol levels. So we've talked about it a couple times, but what do you think some examples of food that is high in soluble fiber?
Maybe raw fruits.
Raw fruits
Raw
and vegetables.
vegetables.
Yeah, very good. Another food group. So beans and lentils tend to be pretty high in fiber, and there's one more to think about.
Isn't bran high in
bran?
fiber?
Yeah, very good. So like, unrefined flour, like whole grains are high in fiber, bran is high in fiber. So very good. So, it's a lifelong disease. They're going to have to get used to reading food labels. Kind of remember that dietetic does not mean diabetic. So dietetic just means the food's been altered, but it doesn't necessarily mean that it's good for a diabetic. So just helping parents to understand what food labels mean and how to read them. You're not just going to be teaching the parents, you're also going to be teaching the child. And then make sure, it's an injection. Insulin cannot be taken orally. They're either going to have a pump or they're going to be injecting it subcutaneously. You should know how to do it. So you never want to be putting insulin into the muscle. So you need to be making sure it's going just into the subcutaneous area. You want to make sure that you're rotating sites so you don't end up with scar tissue. The kids need to start learning really by the time they're 7, they should be learning to inject themselves. So it's one of those things, sometimes parents are kind of helicopter parents and they hover. Kids, they need to be involved as early as they're developmentally able, because this is a lifelong illness that they're going to need to be, learning to manage on their own. We talked about rotating the sites. This one here shows you all the different areas of your body where you have, deposits of subcutaneous tissue, which are good targets for where you would inject your insulin. And then the mixing of insulin. And what are the two insulins that you can mix together?
Is it NPH?
Regular and NPH. And what's the step-by-step as a nurse? How do you go about drawing up two insulins into the same syringe?
Nancy Reagan, RN.
Right. So
do the NPH.
Okay.
And then the regular.
Very good. And then you want to make sure you're injecting the air first, et cetera. Good. Okay. So they sometimes will have an insulin pump. You guys should also be able to recognize, what is a long acting and what is the short acting insulin. Can anyone name a long acting insulin? Which one is faster acting, regular or NPH? So regular is faster. Regular is faster. And then Lispro or Humalog is really, really quick within like 15 minutes. So I would have a basic, understanding. Glargine is a long acting, NPH is longer acting. So insulin shock is just another word for hypoglycemia. It can happen if you get too much insulin or if you have exercised more than you were needed to. So this is something, hyperglycemia over time can lead to ketoacidosis and long-term problems, but you can also get very, very sick from having a blood sugar level that is too low. So what do you do as a nurse? If someone's diabetic, they're kind of irritable, they may be acting a little bit off, maybe they're sweaty, what is the first thing that you do?
Check their blood sugar.
Check their blood sugar, and what can you give them? What is going to bring it up?
Candy,
orange juice. So sometimes you can have like frosting available. You can smear frosting if they're, if they're uncooperative or something. You can smear frosting on their gums that gets absorbed pretty easily. But the main thing you need to do is you need to give them a sugar source to bring their blood sugar up. And need to recognize irritable, kind of off, pale, sweating. These are your classic signs of hypoglycemia. So your immediate action is to give them some sugar, wait a few minutes, and then they might need some protein or something that's going to help stabilize their blood sugar long term. So there's a couple of different phenomenons in diabetes. The first one is this Samoji phenomenon. So this happens, so your body has ways of regulating your blood sugar level. One of them is by releasing cortisol or epinephrine. So when you have Samoji phenomenon, your blood sugar gets low, your body reacts, reduces cortisol, epinephrine, glucagon from your liver, and then you end up with a blood sugar spike. So in this case, it's like hypoglycemia, and then there's a rebound hyperglycemia because the body compensates for the low blood sugar that it experiences. So in this case, they'll have a hyperglycemia, but the root cause could be because they took too much insulin and their blood sugar got low. So it's important to just think about this when you're trying to adjust their insulin, because not all hyperglycemia requires more insulin. It could actually be a problem that their blood sugar got too low and their body reacted and they had this blood sugar spike. So you're going to see this in kids that have been on insulin for a while. Usually when they're on fairly large doses, they have like this hypoglycemia in the night that might go undetected, and then they wake up with a high blood sugar level. So the only thing that you really need to remember about this is that not all cases of hyperglycemia are caused by not enough insulin. It could be a rebound reaction to having a low blood sugar from too much insulin. Whereas dawn phenomena is when you have hypoglycemia, but it's not, you have hyperglycemia, but it's not preceded by hypoglycemia. So they just wake up with a high blood sugar level, but this is not related to the fact that they were hypoglycemic in the night. So in this case, they probably do need some more insulin. So it's just trying to get you to realize that like that early morning blood sugar could have two different causes. It could be not enough insulin, or it could be too much insulin and then a rebound hyperglycemia as a result of being hypoglycemic in the middle of the night. So type 1 in kids is way more common, but just to not forget about type 2. There's more and more obesity within the pediatric population. So obesity, sedentary lifestyle, diet high in fat and refined carbs. These are all things that are a setup for type 2 diabetes. In kids, you're almost always going to start with weight management and exercise, but they might end up on oral hypoglycemic and in severe cases, some actual injectable insulin. So we're going to do a super quick Kahoot, and that's just because I want to make sure that you guys have fresh in your brain what I know you need to know in your quiz. So we'll take the Kahoot, we'll do another 5-minute break, and then you guys can come back and take your quiz and you'll be free to go. So I think there's just 8 questions here. So what occurs as a result of inadequate secretion of insulin? Protein synthesis is increased fat breakdown leads to ketonuria, rapid conversion of carbohydrates to glucose, or serum glucose levels are markedly decreased. Okay, so if you don't have insulin, the first thing that happens is you can't get carbohydrates or glucose into your cells. And then the second thing that happens is fat breakdown leads to ketonuria. So you guys were so serum glucose levels are markedly decreased. When you don't have insulin, they're going to actually be increased, right? You're going to have hyperglycemia. So this one is the best answer. That's you can't use your glucose, so then you end up breaking down your fats and protein, and as a result, you end up with a buildup of ketones. So a child receives a combination of regular and MPH insulin at 8 a.m. At 8:44 or 8:45, breakfast has not been delivered. What should the nurse do? Give the patient a snack of graham crackers and milk, give the patient more insulin, ambulate the patient for a short time, or notify the charge nurse. So good. You guys recognize if you're given regular insulin and it's been 45 minutes, you're going to worry about causing hypoglycemia in this kid. So you need to make sure that you're giving him some carbohydrates for that regular insulin that you gave him. If you just had MPH, this is going to be a long-acting insulin. You're okay to wait a little while. But if they got the regular and they haven't had anything to eat, you need to give them something to eat. So a mother reports that her 4-month-old is lethargic, sleeps 18 hours a day, and snores. What does the nurse suspect? Hypothyroidism, type 1 diabetes, Tay-Sachs disease, or hyperthyroidism? All right, this is your hypothyroidism, the sleepy baby, they can have big tongues, so they snore a lot. Good job. Hyperthyroidism, you would expect the opposite: irritable, jittery, sweaty. After a closed head injury, the child begins to excrete copious amounts of pale urine and has a drop in blood pressure. What do you suspect? Hypothyroidism, diabetes mellitus, hyperthyroidism, or diabetes insipidus? Very good. This is going to be your DI, the brisk urine output, diabetes insipidus, closed head injury. So which chromosomes are associated with type 1 diabetes? 6 and 7, 12, 20, or all of the above? Right, it's all of the above. Good job. So which processes does the nurse explain the endocrine system is primarily responsible for controlling? Stress, growth and maturation, reproduction, or all of the above? So it is all of the above. I would point out it doesn't necessarily control sexual identity because this is going to be more of your personality, but it does control stress, growth and maturation, and reproduction. So which symptoms does the nurse recognize as an indication of synthroid overdose? Synthroid you give for hypothyroidism. Tachycardia, diaphoresis, irritability, or all of the above? Good. So it's all of the above. So either hyperthyroidism or an overdose of taking too much of your thyroid medication. Last one. Which comment made by a school-age child indicates the need for more teaching about diabetes mellitus and exercise?